Welcome everyone to the Kawasaki Disease webinar today. While you're all being let into the lobby, I'm just going to go over a few things. I am Kathy Olevsky, the webinar host for the Vasculitis Foundation Educational Webinar Series. I love doing these informative webinars as I'm also a patient living with MPA vasculitis. You know, there are over 20 forms of vasculitis, and until recently, I didn't know anything about Kawasaki disease. So I'm looking forward to learning with the rest of you today. And for today's webinar, we have three guests. Dr. Mark Gorelick will help us understand Kawasaki disease with his presentation. We also have two parents of children who have Kawasaki disease, Nancy Foster and Nicol Jackson. So welcome, Dr. Gorelick. Thanks for being here as our expert today.
Sure, thank you so much. So let me get started and just, as you said, share my screen so that we can talk a little bit about Kawasaki disease.
You're all set. We see it well.
All righty. So, so this presentation is going to be a brief discussion of, what is Kawasaki disease, and then also a little bit at the end, just because there were some questions about my own research in Kawasaki disease as well. So what is Kawasaki disease? Kawasaki disease is a vasculitis. And so what is a vasculitis? Vasculitis is an inflammation of blood vessels, kind of an itis of the vessels, as the name sort of suggests. And when blood vessels become inflamed, they can become occluded by the inflammation. They can become scarred, in which case they don't dilate properly. Blood flow through them can be decreased, and there can be abnormal blood flow. And so depending on where the blood vessels and the size of the blood vessels that are involved in the vasculitis, you will have various kinds of end organ damage or injury. So certain vasculitis are in medium-sized vessels, and involves, say, the kidney, the vessels that supply the kidney, and decreased blood flow. The kidney can change blood pressure. Small vessel vasculitis in the lungs can cause other injuries, and those are all different kinds of vasculitides. And Kawasaki disease falls under the medium vessel vasculitis family, which is also consists of polyarteritis nodosa, which is a pretty nowadays rare vasculitis. It was actually associated with hepatitis B, and it's become very rare since the advent of the hepatitis B vaccine, but there is still non-Hep B related vasculitis. And these are all the other kinds of vasculitides that can be seen, like Takayasu's and giant cell, as well as ankylosing, etc. So how do vasculitis happen? We don't understand that completely, but one thought is, and if you try to think of yourself from the perspective of a virus or a bacteria that's trying to get into an organism, the best way to do this is to disguise yourself to look like some parts of the organism, because you won't be able to be, or the chances of you being detected are less. But eventually, when you are detected, your immune system, which is a very efficient tool, but not the brightest tool in the world, will go on the attack and look for everything that looks like you, and that not only includes the virus or bacteria, but also the parts in your body that also are reminiscent of that. And that's sort of the molecular mimicry theory of autoimmune disease, and it seems to apply quite a bit to vasculitis per se. And so you will get injury to the blood vessels, which a lot of the organisms have tried to mimic. And so specifically in Kawasaki disease, the kinds of blood vessels that are involved lead to symptoms, physical findings that encompass a couple of different areas. One is rash, and that in part is likely due to the response of the body to the initial infectious process. Conjunctivitis, which also may be kind of similar to that. Redness and inflammation in the mouth and the tongue. And this is actually a true vasculitis. If you biopsy the mucous membranes of individuals with Kawasaki disease, they will have clear vasculitis of the vessels inside the mucous membrane. Swelling of the hands and feet and erythema of the hands and feet, which, we don't exactly understand why that happens, but it is likely both related to the vasculitis and the acute inflammation, and does happen in some other, very severe inflammatory diseases, including toxic shock and also multisystem inflammatory syndrome, which was related to COVID. And then finally, the blood vessels of the organ that are often associated most are the heart. You can get vasculitis in other vessels in Kawasaki disease, so it happens not infrequently that there are other vessels involved, such as vessels around the groin and vessels in the chest, but mainly the coronary arteries are the ones that are affected. And so this is just a picture, a textbook picture, well-known picture actually of a child with Kawasaki's, and this is the other feature of Kawasaki's is these children look sick, they look, very miserable, and it's one of the, although these are the 5 cardinal signs, another cardinal sign really, which is not in the guidelines, is just very ill appearance. So Kawasaki disease is the #1 cause of acquired heart disease in children. And that used to be actually rheumatic fever. But once we got a handle on strep and understood the relationship, we're able to treat that now. And so that is no longer the #1 cause, replaced by Kawasaki disease. And the way generally that we treat Kawasaki disease mostly is with something called immune globulin or IVIG. And the way that IVIG works is essentially, and we don't know completely how it works, but it floods the body with antibodies that appear to block the normal uptake of antibodies that are bound to various pathogenic or various autoimmune epitopes. And so by blocking that pathway, it suppresses the ongoing inflammation. Although, again, there's probably a lot more to that. And when you treat patients with Kawasaki disease, you go down from, of all patients who get Kawasaki disease, about 25% can get persistent vasculitis in the coronary arteries or persistent damage. And the treatment with IVIG cuts that down to about 5%. But that's still a fair number of children. And there are about 3,000 or so cases of Kawasaki disease a year in the United States. So IVIG although IVIG mostly works, there are cases where Kawasaki disease is what's called refractory or doesn't respond to the initial therapy. And that happens in about 10 to 20% of cases. And it mostly happens in patients who are at extremes of age, but it's also the very old or very young patients. And sometimes also patients who have already, severe disease at the onset. And when that happens, there are additional therapies that one can do, either repeat the IVIG, use a pulse steroid dose, or use biologic medication. And this is which one of these to choose is currently under investigation in various studies. There's also what's called incomplete Kawasaki disease, which is important to remember. So incomplete Kawasaki disease is when you have a patient that does not seem to manifest all of the symptoms of Kawasaki disease, and so it can be very tricky. Patients may have 1 or 2 of these 5 cardinal signs that we talked about. So, really ideally, we want to see all 4 or 5 of these cardinal signs, having conjunctivitis, red hands and feet, the mucous membrane changes, and rash. But in some cases, you might only get 1 or 2 of these. And that can be difficult for the diagnostic physician because you don't know whether you're just dealing with fever or rash or not. And it tends to be that the rate of incomplete Kawasaki disease is higher in kids who are young, very young, under 6 months of age. And in some cases, there have been some studies that have suggested that patients who are little infants who are under 6 months of age might only have prolonged fever and then are subsequently found to have coronary aneurysms, suggesting that they did have Kawasaki disease, even though they had none of the other features. And so prolonged fever is one of the reasons to get an echocardiogram in a young infant, like 6 months of age. So another form of Kawasaki disease is called Kawasaki shock syndrome. And this is a kind of an atypical feature. It's about 5 or 10% of all the Kawasaki disease patients. And in these patients, they tend to get shock. In other words, they come in with low blood pressures and some of the features of Kawasaki disease. And it actually is very reminiscent of multisystem inflammatory syndrome, and led us to believe that these two diseases, the multisystem inflammatory syndrome and Kawasaki disease, were related. So this is just a little bit of the pathology that happens with Kawasaki disease, and it's something to understand a little bit more of what the vasculitis means. So these are the normal blood vessels, and a normal blood vessel has 3 layers, what's called the intima, the media, and the adventitia. And when Kawasaki disease begins, the blood cells invade the walls of the blood vessels, and you get this destruction. And following that destruction by these neutrophils, which damage the blood vessel wall, which usually happens in about the first 1 or to 10 days of the disease, you then get what's called proliferation inside the blood vessels. So these would be normal-sized blood vessels in which sort of an attempt at healing takes place, and you can see that sometimes they can become all the way occluded or blocked. And in that case, it can be very catastrophic or dangerous, because blocking of a blood vessel in the heart obviously can cause equivalent of a heart attack in a child. So a little bit about what's new in Kawasaki disease research and in the clinical world. One thing that's new is the recent ACR Vasculitis Foundation guidelines. There have been pre-existing guidelines for Kawasaki disease that are excellent and have been done for years by the American Heart Association. But for some more complex cases where rheumatologists might see these patients, there were some additional recommendations. And some of these additional recommendations are based on recent research. So one of those recommendations is that for patients that appear to be higher risk, and that's a difficult question because we don't know exactly how to define high risk, but one thing that we do know is that patients who are, again, very young at extreme of age, so under 6 months, or patients who have already presented with aneurysms in the first 7 to 10 days when they are first seen, are more at higher risk of either being refractory or having aneurysms that don't want to go away. Those patients can get a dose of steroids with their IVIG and a sort of a course of steroids over 10 to 15 days. And that it apparently, and there's still some studies going on, but appears to decrease the rate of aneurysms down the line. The secondly is we talked about the refractory Kawasaki disease, where you might need a repeat dose of IVIG. And that in our guidelines has been sort of validated as an okay thing to do, but sometimes in some people, repeat doses of IVIG can lead to transient breaking down of red blood cells by an immune mechanism. And so in some patients, use of other kinds of repeat or secondary line therapies is more recommended. Third is use of high dose aspirin. So it has been very much part of tradition that when patients with Kawasaki disease are first diagnosed, they're started on very high dose aspirin. And that's sort of a holdover from the very, very, and I should say I'm getting up there too. So the ancient days when Kawasaki went before IVIG, and in those days, the only therapy was aspirin. So high dose of aspirin were used, but there's really no evidence that high or low dose of aspirin, there's no difference between that dose choice, although using aspirin of some dose is important. So the guidelines suggest that any dose, whether it is low or high, could be used. IVIG remains the central tool for Kawasaki disease in our guidelines. And then, as I mentioned, in the refractory cases, using biologic therapies can be used. In terms of long-term issues, which is sort of really the big question that parents have, what are the long-term issues after Kawasaki disease? Patients who have had Kawasaki disease and have had no aneurysms or even small aneurysms that have resolved generally don't show any greater risk than a general population for long-term bad outcomes later in life. But patients who do have large aneurysms do have a higher risk of long-term adverse cardiac events as they grow up, because those changes in the blood vessels of size and cause clotting, and that can lead to problems, and that's why those patients need to be followed closely and be on anticoagulation therapy. And then finally, in some patients who get joint pain and arthritis, those patients tend to have limited, really self-limited joint pain and arthritis. And so if that is persistent, if a patient has joint pain for many, many months after Kawasaki disease, it may be that the initial diagnosis of Kawasaki disease were wrong, because Kawasaki disease really is a self-limited disease. It's acute, and that makes it different to other vasculitis syndromes for the most part, which are chronic diseases which require chronic therapy. Kawasaki disease is an acute disease that has long-term consequences in some patients, but it's not generally a chronic ongoing inflammatory process. And then in terms of current research, there are a couple of studies going on to look at better medications to cut down on the rate of aneurysm, even after IVIG treatment. As mentioned, about 5% of patients, even after IVIG, still develop aneurysm, and we would like to get that down to close to zero as possible. So there are some studies looking at other or adjunct therapies. Then there have been some relatively recent studies and interesting studies in mice looking at whether specific medications could prevent this remodeling of the vessels. So as I kind of demonstrated, this kind of process where you have the eventual, sometimes occlusion of the blood vessel, there are medicines that can slow down this process if needed. But the difficulty with this question is sometimes you do need a little bit of remodeling to recreate a vessel. The question is how much should you get, and how can you, in those patients, slow down that process? So in mice, there have been some studies. And then finally, just to talk about my own research, was funded quite a long time now. I had a one-year grant for Vasculitis Foundation, and it was looking at a particular protein called follistatin-like 1 protein in Kawasaki disease. And so this is the initial study where we found that patients with aneurysms in Kawasaki disease had higher levels of this particular protein than patients with Kawasaki disease in the middle there who did not have aneurysms. And so the question was, what does this protein do in Kawasaki disease? Now, this is a protein that everybody has in their blood, and there's no, as far as we know, there aren't people who have none of this, because it's a very, very important protein. So you can't be born without this protein. So really, it's thinking more about what is this gene? What does this gene do? Is it something that could be blocked, cause a problem, or is it helpful? And so this is a cross-section of a mouth part, which just shows on the right a normal mouth part, and the red is the lining of the heart. The red here is the lining which shows where the protein is expressed, and on the left is a cross-section of a heart, and you can see all this extra red is the extra epithelial-1 that is expressed all over the heart. So it's not only in the blood that we see epithelial-1 after Kawasaki disease, but it's also expressed all over in the heart. And so when I looked at trying to block this protein, what we saw that was without this protein, mice who got a very high dose of an agent that causes them to develop a Kawasaki-like syndrome seem to have a decreased rate of survival. So it seemed to suggest protein was protective. And when we also looked at the hearts of these mice, we found too that mice who have this protein which is knocked out have higher levels of inflammation. So all of these graphs, the leftmost bar graph, all these points on the left of these three graphs show the increased number of blood cells in the knockout mice as opposed to the normal mice. And so it really telling us that this is a protective gene, a protective protein. When we did something very high tech, we took these little cross sections of the heart, and we actually dissolved them almost into cell suspension. So sort of every single one of these dots represents a little cell that we kind of dissolved and made in a kind of almost like a liquid form. And then we could tell which cell was which using a sophisticated genetic technique. And we then wanted to see what would happen, what is happening in our mice that don't have these genes turned on. And what we found is in many of the cells, and this is our gene that's knocked out, we should see that, and this is a very, very complicated chart, but basically what it tells us is there may be a gene, another gene, which has got a fancy name, EBTB16, that is related to FSCL1, and that without FSCL1, you get increases of these two inflammatory genes. And so it's telling us a little bit about the mechanism behind FSCL1. So there'll be next steps. But so this study was, initially something that had been a long set of work, and initially the initial results were not as interesting as they are now. But that's where we are today with the research. So that's the end of my section, and I will stop sharing my screen.
Thank you so much, Dr. Gorelick, for sharing that interesting information. I think we're going to come back to you with a few questions. And before we do that, we're going to talk to two parents. Those of you that joined us late, I wanted to let you know that there is a Q&A box that you can submit questions to for Dr. Gorelick or for Nancy and Nicole. Anybody will be happy to take your questions. If we can answer them, we will. And so you can just look for the Q&A box, put your question in there, and as soon as we get to it, we will. We kind of kept everybody muted so that nobody can verbally ask the questions, because that helps us reduce background noise for the recording that we're going to put up later. So if you would mind just submitting your questions by putting them in the Q&A box, that would be great. Okay, and I would like to start by introducing Nancy first. Nancy Foster's son, Jason, had Kawasaki disease at age 7 in 2002. She's been a volunteer for the Kawasaki Disease Foundation for 20 years, a member of the Kawasaki Disease Facebook support group for 15 years, and a group moderator for 3 years. And they live in Fairhaven, Massachusetts. And so Nancy, would you tell us a little bit about your story with Jason and the journey with Kawasaki disease?
Yes, thank you. In many ways, I think Jason's story is typical, although he was slightly older than most children when they contract Kawasaki disease. Generally, it's infants to age 5, but it does occur in older children. He was almost 8 years old, and he was initially misdiagnosed by our local pediatrician, which is a common story in 2002, but in 2023 as well. I fortunately had heard briefly of Kawasaki disease earlier in my parenting life and kept looking for information, and returned to the pediatric office a few days later when he became sicker, and he was seen by another provider who recognized Kawasaki disease and immediately sent us to Children's Hospital for treatment. Jason was very fortunate. He made a full recovery, but my experience of having to keep pursuing the diagnosis and asking questions made me want to help other parents in similar situations. So a year later, I became a parent volunteer with the Kawasaki Disease Foundation, which had been founded in Massachusetts in 2000, because there was a lot less information available online in those days. I was a moderator for a couple of their early versions of online forums. Then as times evolved and parents found it easier to access information and support groups through social media like Facebook, Nicole had already started her group, and I had joined that quite early on, and then became involved the last 3 years as a moderator. Jason went on to do speaking for the Heart Association and for various local media and all on his own, always being grateful to make a full recovery, played sports all through school, and currently runs 10, 11 miles every day, 365 days a year. And I continue reading as much and learning as much as possible, because there's always a new parent hearing that their child has a rare disease.
Well, thank you so much for sharing all that. Thank you for doing all your volunteer work too. I'm sure that you've helped so many parents with this disease that can be sometimes very scary when you first find out about it. And I think we'll come back to you in a little bit to see if you have any questions after we go through the questions that some of the other parents have asked us. And I'd like to, at this time, go on to Nicole and say Nicole is the mother of 23-year-old Josh, who was diagnosed with Kawasaki disease at the age of 5. They live in a small town outside of Niagara Falls, Ontario, Canada. Nicole established the Kawasaki Disease Support Group on Facebook in 2005 to help spread awareness and support other families going through the same process. So, Nicole, I know that your journey with Kawasaki disease is kind of unique, but why don't you tell us a little bit about your son's, Josh's, journey with Kawasaki?
Okay, thank you, Kathy. And thanks everyone for coming today. It's really good to see so many faces and to get all the information we can from Mark. I sat with Josh at 5 years old. He was sick for about 8 days. We lived in a very small town, population 400. And our small town doctor had just gotten out of school, thankfully, because I credit that to him catching KD. Josh was originally diagnosed with an ear infection. So 8 days in, we took him back. The doctor did some looking into his books and decided that he had Kawasaki disease. We were sent to a pediatrician who immediately sent us to the hospital where Josh was treated for KD. He had a temperature of 104. He had swollen up and just was not my child. No way did that look like my son. So they started the IVIG after they did the heart tests and a bunch of blood work. Josh became very lethargic and flatlined. So I stood there for 2.5 minutes and watched as they, resuscitated my son. That is when I decided to start the KD group. Josh was 2.5 minutes flatlined. They shocked him back. And I was told at that point that the IVIG was treating him, but it was also killing him. So he unfortunately had an allergic reaction to it. So the doctor looked at me and said, what are we going to do? We have 2 choices. We can give him the IVIG, which is killing him, or we cannot give it to him and that will kill him. So our choices were slim. We were worried and ended up what the doctor did was pumped him full of Benadryl. The Benadryl saved his life. So we were in and out of the hospital, I'm going to say, for 2 years. Josh got better. We got him home. He had severe skin issues, all sorts of the KD regular things. 2 months later, he got very ill again. We were sent back to Toronto Hospital and he was diagnosed a second time with Kawasaki disease. This, I would like to stress, is not common. So Josh was put in the medical journals because he, at that point, was one of only 2 Canadians that was ever diagnosed twice. So a lot of people feel like their child, once they have it, get it again. But Josh was actually officially diagnosed, and I always like to stress to people it's not common. It may feel like it looks like it, but it might not be. So 23 years old now he is, still has rheumatoid arthritis, still has a lot of skin conditions, but he's a trooper, keeps going every day. And I'm very thankful that Nancy joined my group when she did. I think she was like literally one of the first 5 people that joined my group. And she's been amazing at helping me the last few years, like really diving in the last few years, moderating. And I'm grateful to have our group and to help as many people as we can to educate them in KD.
Well, thank you so much. I think both of your stories are unique. And I think, if I'm not mistaken, I heard you were working on a book. You want to tell us a little bit about the book?
Yes. So what I did was I started a book for children for Kawasaki disease. A few years ago, I started making t-shirts. that had KD stuff on them, and I started making superhero capes. My mother taught me how to sew a long time ago, so I put that to work, and I put the superhero in training on the back. So I was giving that to kids in the hospital that needed to feel like a superhero. But since then, I started my children's book. I just have finished the illustrations, and it is now going into production. So it should be ready in about 2 to 3 weeks. And I'll make sure I put some of those on our group, and hopefully people can get them out there. It's not just for kids with KD. It's for any kid that, you know, needs to feel superpowers when they're in the hospital and overcome their fears. And I'm entitling it The Little Warriors.
What a great process and a great thing to do. And I'm sure if people want more information about that, they can look on in your Facebook group, and you'll let them know. Okay, I think we're going to move on to questions for Dr. Gorelick. And if anybody wants to drop any questions into the Q&A box, maybe some of these questions will make you think of other questions. You can also ask questions for Nicole and Nancy if you just have parenting questions you want the answers to. Also, we will give them a chance to ask questions if they think of some after the fact. All right, back to you, Dr. Gorelick, if you want to unmute yourself. Since well, first question was, since inpatient care is managed by hospitalists now and pediatricians may not be familiar with KD management, who should a parent contact if their child shows signs of symptoms such as a fever returning after the first few days after they've been discharged from the hospital?
Well, so I would say that pediatricians should be familiar with Kawasaki disease. Actually, I think that I would say that the person to contact would be your pediatrician. All pediatricians should have seen Kawasaki disease during their residency and should know what to do. And if there is a return of a fever, in the 2 weeks after Kawasaki disease, that child may have recurrent, a refractory Kawasaki disease, basically. In other words, the first dose of the IVIG may not have worked to get rid of it completely, and so that child should go back to the hospital and probably, in most cases, get retreated. So, yes, it's true that Kawasaki disease is treated by hospitalists, but both those hospitalist pediatricians and your general pediatrician at home should know exactly what to do in that scenario. And that we also sort of addressed it in the Kawasaki disease guidelines, so that's something that your general pediatrician would have been able to read as well.
So again, be your own best advocate, know as much information as you can, and go back to your care provider, your pediatrician in most cases.
Right, and the hospitalists do know, they should know what to tell people to look for when they've been discharged. And one of those things to look for is recurrence of fever. And so those anticipatory guidance is usually given, and obviously things fall through the cracks, but the answer is to go back to the hospital, touch base immediately with your pediatrician, and both of those folks should know what to do.
Okay, another question is, what are the current recommendations for long-term follow-up for children with no cardiac complications? I know that parents worry that they might overlook something that would be important.
Right. So, those patients who have had no coronary complications at all, and who don't have to see a cardiologist, etc., those patients should consider themselves no different than any other person who's had an acute disease and who has recovered. Theoretically, one could imagine that it's possible that there might be some changes to the blood vessels in a patient who has not had aneurysms, but when those studies have looked at all of those patients over many, many years, there isn't a signal that they are at a higher risk than other patients. So, if you're following as a cardiologist because you've had an aneurysm, then that is because you're known that you have a higher risk. For those patients who have had Kawasaki and don't have any subsequent aneurysms, they should consider themselves to have dodged a bullet and live a normal life.
Great to know. After the acute phase of Kawasaki disease, a child is recovering in general but continues to experience joint pain. At what point do you recommend a referral to a pediatric rheumatologist?
So I think that you can always, ask your pediatrician to refer you to a pediatric rheumatologist if the child is having joint pain. And so really at any time that you're having joint pain after Kawasaki disease, you might want to see a rheumatologist. But the joint pain that happens after Kawasaki disease is generally transient. It can last up to 3 to 4 weeks, and can be a true arthritis, which means there's swelling of the joint and inflammation of the joint itself. But it is always self-limited. It's not something that persists. And if it does persist, it may mean that there is a different diagnosis. Kawasaki disease can look like other things, and there are other rheumatologic diseases as well that can sort of look a little bit like Kawasaki disease, but have long-term persistent arthritis afterwards, and that's a different disease. So persistent arthritis means definitely go back and see, your rheumatologist.
One parent wants to know how to stay informed about the latest Kawasaki disease research and developments. Any thoughts on that?
I think that it's always hard to stay in touch with what's going on in the world, especially in this age of disinformation and misinformation. It's hard to know. But I think that groups like the Vasculitis Foundation, the American College of Rheumatology are good groups that have publications on their websites and updates, and those are good places to sort of look for information.
Okay, and I just had another question come up that I was asked to ask you. We're not sure everybody knows the difference between acute and chronic. Could you explain how that?
Sorry. So, the difference between acute and chronic is, in general, in medicine, when events happen, they are either sort of self-limited or they take a life of their own and they persist, on their own steam. So things like your common cold, those tend to sort of come and go, or any other kind of event that sort of comes and then resolves by itself, is sort of oftentimes acute. But when you have something that lasts for weeks and weeks, and then persists for months and months and then becomes part of your life, that is a chronic disease. And so that's the difference between something like Kawasaki disease, which tends to be acute and, with the exception of the damage that happens afterwards, self-resolving, and something, say, like ANCA-associated vasculitis, which sticks around because there's some sort of change in the immune system that is basically permanent, and it can be put into remission through use of medication, but it generally requires use of medication to keep it in remission.
Okay, and let's see. Let me just check the next question. What surprised you the most about the study that you did? Has there been new developments or research that uncover causes of scar formation with Kawasaki disease?
So our research was initially looking at how this protein was related to scar formation. And so the surprise was, I guess, that what we thought would be related to scar formation was instead related to inflammation itself, or scar formation, which is different, which is something that happens after inflammation, that the protein is really involved more in the inflammatory process than in the scar formation process itself.
Okay, and I know your process was a result of a Vasculitis Foundation grant. I think I got that correctly. Mm-hmm. What can we do as a society to support research on Kawasaki disease and improve outcomes?
Research, the difficult fact of the matter is that research does require funding. And so all of these organizations that provide funding, and including, the National Institutes of Health, et cetera, require support in terms of dollars. And that makes, all the difference in the world. But I think that the important thing to also know is that all of science research is feeds into each other. So what research in one area can apply to Kawasaki disease, just as research in Kawasaki disease can apply to other areas, say a blood vessel disease or inflammation, things like that. So by supporting research in general, you're supporting Kawasaki.
Always good to point out when we have the opportunity to. It's just like many of the vasculitis situations, is that one thing often does direct progress on another one as well. So we do want to support all the research. I have a couple of questions for Nancy and Nicole. What do you think, either one of you can answer this, what do you think parents can do to help raise awareness of Kawasaki disease in their communities, since you're both involved in raising awareness? Either one of you want to talk?
Okay. One of the things that I recommend to everyone, and many people have asked over the years, is something that is almost cost-free, but every family could do. The American Heart Association sponsors the American Heart Walk at locations throughout the country, generally in the spring, sometimes in the fall. Back in 2003, Jason started a team called Kawasaki Kids. We made up t-shirts on our own. We gave information to his pediatric cardiologist. We made bumper stickers and put them on their cars. I even had some people stop me in parking lots asking, what is Kawasaki disease, when they saw the bumper sticker. When we walked each year in the Heart Walk, we wore our shirts that said, ask me about Kawasaki disease. And so we did raise a modest amount of money, but what we really hoped we were doing was raising awareness. And the more people who have heard of it, should their child ever develop symptoms that could be, they may be more quickly able to seek care for their child within the 10-day time frame for treatment.
Okay, that sounds like a great effort. I understand. I think there's a Kawasaki Disease Day. Nicole,
Yes.
Nicole, do you want to
Yes.
tell us anything else about that?
January 26th, right, Nancy?
Yes.
So that was dubbed National Kawasaki Disease Day. So we try to spread awareness on our group. I know for us personally, every time we had a chance to do something at the school, within the community, we always push forward, just because honestly, getting the word out is the biggest challenge. The more people that know about it, the less people that are scared of it.
Yeah.
I also, as soon as you get the old jokes about the motorcycles, right? So I just roll with it. Yeah, it's like a motorcycle. Change your oil, just like we got to put the IVIG in and change everything inside to make them better. So if people have to relate it to a motorcycle, so be it.
Okay. Well, I want to I've got two more questions for you guys. I want to make a last call to anybody that's watching to put a question in the Q&A section if you'd like us to ask Dr. Gorelick or Nancy or Nicole. I did want to say that I wanted to ask about the Bridges program through the Kawasaki Disease Foundation. Can either of you address that?
Yes, that's the part of their foundation that I've been part of. It has a director. Her name is Karen Wicker. She's also a parent volunteer and a board member. And basically what it does is their parents can request to become a volunteer. And they ask you some questions about various background and all. There's online training available for the program. And then you are willing to be sent a request from the program director that would ask you to contact a parent who has reached out to them by email or by phone, depending on the parent's preference or the volunteer's preference. And again, very clearly, we don't give medical advice, but we're good at listening and sometimes being able to tell your story to someone who understands what Kawasaki disease is can be beneficial. And we try to help provide education so that parents can ask better questions of their child's care team.
Wow, that sounds like a great program. I have a question for Dr. Gorelick, and this comes a little bit from conversations with both Nancy and Nicole. Are there any special long-term precautions in children's activities that are needed after Kawasaki disease? They both have said sometimes parents themselves become maybe more protective than they need to be, that their kids are both doing very well.
No, there aren't. I think a child who had Kawasaki disease either not had any problems with the aneurysms or is on appropriate therapy, should feel free to be a child and be active, because that's really the most important thing. Keeping your heart healthy, etc. There may be some instances in which people have very, very severe aneurysms and are on certain therapies where a cardiologist might put in place some restrictions. But in general, there should not be, any kind of restriction.
That's really great to hear from a medical expert. I think it's important that the parents know that. Well, at this point, I think I'd like to thank Dr. Gorelick, Nancy Foster, and Nicol Jackson for all that they did to contribute to this great webinar today. We sure hope that this sheds some light on sometimes difficult, even scary situations that families find themselves in after a diagnosis of Kawasaki disease. And of course, thanks to the Vasculitis Foundation for making these educational webinars possible. We do have some additional resources that we think may help out in the future. You can find the Kawasaki Disease Support Group, the one with 8,500 members on Facebook. That's a great group to resource to communicate with other parents. There's also the Kawasaki Disease Foundation website is a great resource. That would be the kdfoundation.org. And also the American College of Rheumatology and Vasculitis Foundation treatment guidelines for Kawasaki disease can be found on the Vasculitis Foundation's website at vasculitisfoundation.org. So thank you to all three of you for giving this great information to the parents dealing with Kawasaki disease. We appreciate your time, and thank you so much.
Thank you, Kathy. And
Thank you for inviting me.
Yeah, Ed and Jennifer, you guys, it was great to be a part of it. And Mark, you're very informative. That was awesome. Thank you.